was a wonderful presentation. I mean, it just, to me, it encapsulates everything we're trying to achieve, really. If you can get a really good pulmonary rehab program going, it brings in the multidisciplinary team, the community love it, and it brings in the community, as well. It brings in the other caregivers, and it's so key. The first pulmonary rehabilitation program that was established in New Zealand was in 1991, and I'd just been overseas learning how to do lung transplantation, and we established lung transplantation at Green Lane. We were the sort of 8th pulmonary lung transplant program in the world. And one of the things I learned on that was the importance of getting people fit for the operation. The fitter you got them for the operation, the better they did. So that was the incentive to develop the first rehab program, which is a completely wrong reason to do it, But I had a letter which I should actually frame, which was from this lady who had COPD, alpha-1 antitrypsin deficiency, and she was age 60. And she came to the rehab program, and she wrote me a letter at the end of the program. She said, "Thank you very much for all your interest and time. I'm really pleased that I've been accepted for a lung transplant. But now that I've done 10 weeks of pulmonary rehab, I feel so much better. I don't think I need it." And so it became obvious to us, I think you need to do a pulmonary rehab first, and then at the end of that pulmonary rehab, try and work out whether or not a lung transplant is still required. So I remember that well, and I thought it was a great presentation. I think if you could stop coughing for a while. I was going to ask. Sorry about that. Yeah, but the other thing I think it came up in that was accessing the multidisciplinary team as well. So we sort of developed electronic referrals from GPs and from the hospital back into our system, and I was on that sort of group. It's really important you can access the nurse specialist and the physio without having to go through a respiratory physician. So I think it's key, and it's important that GPs have access to the multidisciplinary team. They're very capable of working out whether I need to see somebody or not, but it's only exceptionally that you'd get me to see somebody because you think, well, the diagnosis might not be right, or I think they need a bit more effort spent on getting their medications right first. But
and we pick up some good things. We pick up some interesting things: lung cancers, pulmonary hypertension, tumours, all sorts of things in the course of our assessments. So.
Yeah, a lot of diagnoses made. The other thing that I think came up in that discussion was sort of case management, because you do that really well. So, these are people who are frequent attenders, frequent flyers. I just wonder whether you mind just teasing that out a bit more, because you do an outreach program, and we actually evaluated that, but just how you ease people back into the community and how you work with GPs and the practice nurses. Do you want to just mention that just quickly?
Yeah, absolutely. So part of patients coming into the program, there's a few ways patients can access the multidisciplinary team and case management model. Some of those patients I see might be from the ward. I do a ward round for a couple of hours every Thursday morning, or the team might send me a referral and say this person needs a little bit of extra just hands-on, and it could be that I then see the person going back into the community, because I'll get to see them before the physician will see them back in clinic, and can flag up some problems with what's going on, and at that point liaise between the GP, the patient, the physician about what's happening with that patient care, and we can get some interventions put in really, really quickly if we need to. Patients coming into pulmonary rehab, by the same token, there are patients sometimes that are referred in. They might not make a first assessment, but I've seen the referral. We'll have a chat with the person on the phone and then say, actually, I think we need to do some work before we get you come to pulmonary rehab. And at that stage it could be, again, liaising with the GP, or sending a referral through to the physicians, or getting them to come into clinic where I work alongside an SMO and a physiotherapist in a general respiratory clinic, and we can get a bit of multidisciplinary eyes on this person to help just improve their health. That intervention can be as short as 1 or 2 visits, or it could be going on for, Jeff and I have had patients that we're still seeing. We've got patients who have got involvement from the transplant team, and they see Jeff and myself, the transplant team, and we all have a different role in keeping that person as optimally as well as they can be, and the roles are different, but we all liaise with each other, so we're able to keep each other in the loop. Particularly with people with more severe disease, our physicians, some of our physicians will go and do home visits, but for the most part their time isn't there in the community. And so I can do the eyes and ears things, you know, what's actually going on in this home situation, what is it we can sit down, and I'll often go and see a patient at home, and then we can sit down in case conference, what is it that this person needs, where can we bring the GP and the practice nurse in, what are the other interventions we need, what are the agencies, and it works really, really well.
Might be worthwhile if we get time at the end of the day just to talk about other people's experiences, because I'm sure everybody does it slightly differently no matter where they are, so it'd be quite useful just to have a chat about that. I'm going to go just down to pulmonary clearance techniques, and I guess some of the issues, if we're going to talk about antibiotics, which I'm going to do at the end of the day, it's important to consider the airways as part of the immune system. And really the people that get into trouble with neutrophilic inflammation, bacterial infection, invariably are colonized with pathogenic bacteria. And you have to understand why that might happen, but usually it's because they've got damage at the cellular level and they've got impairment of their mucociliary clearance apparatus, and or they've got impairment of cough. The actual, what's available to us in our airways in terms of maintaining immunocompetence is actually quite complex. I'm not going to go into that, but I'm going to say that there can be breaches at a number of different levels. But the breach that's most important is the breach that happens at this sort of cellular level here. So what we have is we've got two fluid levels that actually are over the top of the airways. One actually bathes the cilia, and the other one sits actually on top of that. So the periciliary sort of fluid layer is of critical importance. And what happens in people with bronchiectasis, even people with functional airways disease, or even anybody who's got a prolonged protracted bronchitis, instead of having a nice little stream running along here, they will have puddles, and they've got a breach as a result, and they're less good at getting rid of particles, and they're less good at getting sputum and also bacteria out of their airways. So that's why they critically need people like Sarah to help them in terms of mucociliary clearance, and we need to reflect on what other things are available to us as well in terms of managing that. So what are the causes of mucociliary dysfunction? There's a lot. There's asthma, there's a protracted acute bronchitis. Of course, if you're cigarette smoking, you're going to do it over a period of time. Chronic bronchitis, CF and bronchiectasis, the classic ones. Primary ciliary dyskinesia causes problems that lead to this. And of course, as I said, the functional small airways damage as well. I've mentioned to you about that. I think I'll just race through some of these things in time, because it's a little bit theoretical, but you can reflect on it later if you want to look at this in more detail. Effectively, if the cilia are damaged, which they often are as a result of a bad infection, or particularly as a result of chronic inflammation, then they're not going to beat properly and beat well. And what happens subsequently is the mucus gets impacted, it changes its rheology, it becomes more resistant to moving, and it's harder to move. And you end up with an abnormal interaction between the cilia and the mucus. And as a consequence of mucus plugging, you end up with increasing bacterial loads and increasing risk of recurrent infection. So there are medicines that you can use to try and improve things. These are actually, the pharmaceutical companies will tell you that they're really useful. They're useful in the laboratory if you look at things on plates and that, but in clinical practice, most of these things don't actually contribute any useful benefits. Amiloride as a diuretic in cystic fibrosis had some small benefits. Obviously steroids and asthma, we don't need to reinforce the importance of that. These drugs, of course, inhibit mucociliary clearance, so we've got to be careful about overusing those. And I won't get onto that. So there are obviously things that we need to do to try and improve on that. So this is something that we got money from the Knowledge Economy Fund, and Harry Ray and I helped Fisher & Paykel Healthcare develop the Airway device, which is the use of long-term humidification therapy, and we subsequently studied it and published on it. This is the device. It's attached to the wall, and it basically causes humidification. Patients wear a nasal prong, which actually fits very snugly into their airway, and interestingly, it provides about 4 or 5 centimeters of PEEP. So it's actually quite useful to use during an acute exacerbation of bronchitis in people with COPD, because it reduces their work of breathing. And so we use it now routinely in all patients who are admitted to hospital with bronchitis or with bronchopneumonia. You can see they can be plugged into it and plugged into the wall. And in the study, we offered patients the opportunity. They said you had to use it for a minimum of an hour a day. Interestingly, some patients actually used it overnight because they found that they slept better. And interestingly also, many people who have impaired mucociliary clearance down here also have impaired clearance in their upper airways, and a lot of patients reported improvement in their upper airways symptoms as a result of using it. So the study that we undertook was COPD 63 patients, bronchiectasis 45. They had to have had more than 2 exacerbations in the previous 12 months, and we randomized them after they fulfilled the 108 we recruited to either treatment or to usual care. You can see a few got lost to follow-up and a couple died. These were quite severe patients. As usual in these trials, over a year, a few withdrew and 1 or 2 moved to other DHBs. But we ended up with most of the patients getting through to a year and therefore being available for evaluation. And we looked at a whole lot of different outcomes there, but the main one was exacerbation frequency. We used criteria which was of increasing cough and sputum, and it's a validated way of doing that, and or whether they needed antibiotics and people weren't using biomarkers and or steroids. But basically what we found was that there was a reduction in the frequency of exacerbations. It didn't quite reach significance, but the number of days that they had an exacerbation for certainly did. The days to exacerbation, which is actually now the most commonly used outcome measure for any study in bronchiectasis or chronic bronchitis, was substantially prolonged. The problem with them is once these guys get an infective exacerbation, of course they end up with a lot of antibiotics, which then impacts on their subsequent course and sort of effectively reduces the likelihood of showing an efficacy from the intervention. So these guys ended up on a lot more antibiotics, and as a consequence of which, of course, they derive some benefit from that. So it reduces the benefit of an intervention. But nevertheless, they did better. And even their lung function was better statistically. It was a very small improvement, but it was better. And their forced vital capacity was better as well. And their St. George's quality of life was 4 units better, which is, has to be a minimum of 4 units to show clinical benefit. So patients actually did well, and they actually improved this. They didn't improve. These people had quite severe COPD. So if you plot them over time, if they've been to pulmonary rehab, their 6-minute walk test is generally going down. So they went down less than the patients who didn't have the intervention. So that's really, in a way, it's sort of trying to create humidification in the airway. We assessed it by looking at some really clever tests by getting people to inhale isotopes. And if you follow them with a gamma camera and you've got normal serial function, you'll clear all of those radio-labeled isotopes within about 24 hours. But the people that we recruited, on average, took 4 days for them to get rid of the radioisotope-labeled particles. But if they took the Airvo device, on average, they got rid of it within about 36 hours. So it substantially improves mucociliary clearance, and undoubtedly that's how it works. I've been doing some work with a group over in Sydney as well, which is looking at inhaled mannitol, which is a hyperosmotic approach, which is within, and you can use hypertonic saline as well, to try and achieve, in fact, the same thing. In that way, you're trying to extract fluid out of the cells and to create an improvement in the fluid environment and also in the rheology of the mucus. And you can show the same sort of benefits with mannitol that we saw with the high-dose heat humidified air device. But although they had short-term benefits, their benefits haven't been sustained as well as they were shown in our patients. And about 30% of patients on inhaled mannitol cannot tolerate it because they develop bronchial hyperreactivity on it. So inhaled mannitol is actually, we thought it was going to be good. We thought that the sort of improvements that we were observing in patients were similar to what we were seeing with the Airvo device. But in fact, as it's translated, the Airvo device seems to be better.
What are you using in the Airvo? Is it water or is it isotonic?
Yeah, it's water, yeah. So So basically, it's just basically creating. Yes, so it's water. So so in terms of treatment of mucociliary dysfunction, I just mentioned those things because to try and improve that. But there are other things that we should be considering using as well. And I thought it would be useful, since so many of our patients have chronic sputum production, whether it be bronchiectasis or chronic bronchitis, that maybe Sarah should just share some of those techniques with you.